What I'm going to do today, I'm going to talk about hepatitis B and C in our rheumatic population. I'm going to give you some basic facts and about these two viruses. And I'm going to mention what is really the risk for reactivation, mainly with hepatitis B virus using our medications, how to screen and how to treat these patients, and how to monitor these patients during therapy. First of all, these are common diseases. As we heard yesterday, we are living with microbes, but we are also living with a lot of viruses that cause latent or chronic infections. And among them, the most important and most serious ones are the hepatitis B and C virus. And as you can see here, they account for about 500 million infected people worldwide, or 7% of the world population, which is a big problem, especially in certain areas of the world, as I'll show you later on. And certainly, there is a geographic variation in the prevalence of these two viral infections. And there are areas like, for example, in North America, you see more hepatitis C virus, whereas in Europe still we see a lot of hepatitis B. And, but if you go to other areas of the world, still hepatitis B is the most common chronic viral infection. I'm going to start first with hepatitis C virus. I'm not going into too many details about the virus, just to remind you that it is being transmitted parenterally. There are 6 genotypes that you don't need to worry much about. These are important only when you start treatment with interferon, and we know that the virus targets the liver cells and replicates in hepatocytes. There's a lot of discussion about its replication in other organs like and cells like lymphocytes. As I said before, this is still a global health problem. 2.5% of the population is infected, 180 million people, and there are about 350,000 deaths every year. As you can see, there are not too many cases, new cases now in the US or Europe. There are about 30,000 a year, but if you look at the rest of the world, there are about 3 to 4 million new cases every year. So this is an ongoing problem. Now, there's a question whom to screen. In the past, we were saying you have to screen people who use drugs or had been transfused before 1992, people who have high-risk sexual activity, or healthcare workers. But as you will hear a little bit in the next slide, now the CDC recommends that everybody who's born between 1945 and 65 that should be screened for hepatitis C virus. The screening is easy. You do first the antibodies, you do the commercial ELISA. If this is positive, then you order an HCV RNA. If this is positive, then your patient has chronic infection. If it's negative, this is an old infection, you don't have to worry. You don't care about, as you worry in hepatitis B virus, about reactivation. These people behave like the ones who have cleared the infection. So you don't need to worry for patients who have just antibodies and no RNA. Now, this is a major health problem, and probably Nizar can help us with some of that. We know now that in most areas of the world, developed areas of the world, the infection rates go down, but as you can see, the next 15 years, it is expected that the number of patients with cirrhosis will increase in this country. So this is an ongoing problem, and that's why the CDC in the late 2012 recommended that all people who are born between 1945 and 65 should be screened for hepatitis C infection. And that means it's easy to remember people who are between 45 and 65 years old. And as you know, this is the group of patients that we usually deal with, especially in rheumatoid arthritis. So everybody should be screened regardless of their risk for infection. Now, how about the natural history of the disease? We know that about 15 to 30% of patients develop cirrhosis over the long run. And we know that factors that accelerate this course is the duration of the infection. If you get the virus after the age of 40, alcohol use, co-infection, and males develop cirrhosis more frequently than females. Now, is there a difference in the prevalence of the disease between our patients and the general population? And the answer is no. This is from a recent study from France, from Dugados, that showed that essentially the prevalence was exactly the same between patients with early inflammatory arthritis and with the general population. So, do we need to worry about these patients when we give our medications, including steroids, synthetic or biologic DMARDs? And we're going to talk more about anti-TNFs and rituximab that we have more data. First of all, what about steroids? And there is some good data from the 90s that showed that if you use steroids, even in high doses, moderate to high doses, like 40, 50 milligrams a day for a period of 3 to 4 months, nothing really happens. The HBV RNA may go up a little bit, but then it comes down to the pre-treatment levels, and the ALT, if it was elevated, goes down, and that's because, of course, you suppress the immune response, but then it comes back to normal. Now, we do not have adequate long-term data using low-dose steroids, so we don't know much about the incidence of fatty liver and other things that could happen, but overall, it appears that short-term use is safe. How about other immunosuppressors that we are using in our patient population? And mainly the data, and we're going to discuss that in the second talk, come from patients with cryoglobulinemia that got cyclophosphamide or high-dose steroids. For a period usually less than a year, it seemed that there was no increased risk for reactivation, and more importantly for hepatitis or decompensation of the liver disease. So short-term therapy appears to be safe. Again, we don't have long-term data for these patients, but if we take the experience we had with cryos, it doesn't seem to be a big problem there. Now, do we have enough data with medications like methotrexate or leflunomide? Again, the literature here is very poor. We do not have enough data for this patient population. And what is more important, we do not have data for patients who have underlying cirrhosis, who we know that are at higher risk of developing infections and other complications. How about anti-TNF and biologics in general? I would say from the beginning that we have more data with anti-TNFs than with any other biologic. This is from a recent literature review that was published about a year ago, about 150 patients that were treated over the years with anti-TNFs. The majority of them got etanercept, about 70%, and what is reassuring is that there were only two cases of confirmed or probable worsening of HCV-related liver disease. So I think that we have more data on liver safety for these patients than with any other DMARD, and it appears that this is a safe option. And actually, it may have some antiviral activity, and I'm sure Nizar is going to present some of this data. How about other biologics? The only one that we have data on is rituximab, and again, the data come from patients who had cryoglobulinemia. We know that in the short term, there are no significant side effects. There is no increase in the HBV RNA levels, and it is interesting that even when they gave it in patients who had cirrhosis, advanced liver disease, nothing really happened. But again, these were short-term studies. We do not know much yet about the effect of long-term use of rituximab. So, as I said before, the recommendation now is to screen everybody. Again, it's interesting that if we look at our recommendations in the rheumatology literature, really there is some confusion here, and Len has mentioned that in a recent editorial that he published. In the recent updated consensus statement says you do it before anti-TNFs, in the past only in the presence of risk factors. But my recommendation would be to do it for everybody who's going to start methotrexate, DMARD, or biologic therapy. How about medications? I think the ACR has done a good work on that. They suggested that you avoid methotrexate and leflunomide in these patients, although I think in patients who do not have advanced fibrosis, and you may have to use it, you can use it as long as you monitor these patients very closely. How about biologics? They suggest that you can use them in like anti-TNFs, rituximab, or abatacept in patients who do not have advanced liver disease, who do not have decompensated cirrhosis. In the recent update of the 2012, they recommended that etanercept could be the preferred agent, probably because we have more data in the literature, although it appears that the other anti-TNFs are also safe. And also, in the recent update consensus statement, there was no really toxicity with anti-TNFs that was mentioned in the paper. Now, how about what is the algorithm in these patients? First of all, and Nizar is here, and I'm sure he agrees, when you have a patient like this, it's always important to consult with your hepatologist. And it's important not only because he has to do an evaluation of the liver disease to be sure that this patient doesn't have cirrhosis, doesn't have portal hypertension. And more important, this is from a public health point, you have to decide whether or not you give antiviral therapy in these patients in order to clear the virus. And there are other things that the pathologist needs to do to evaluate whether or not there is fibrosis or inflammation and decide whether or not a liver biopsy is warranted. Now, in patients who do not have advanced liver disease, have mild disease, you can use any biologic you want, and I think in some cases you may even use DMARDs, but you have to be very careful with that. Patients who have fibrosis, either by liver biopsy or other means like the transient elastography that it assesses fibrosis, I think it's better to use biologics alone without DMARDs. And obviously at that point you need to discuss antiviral therapy for these patients because they really need it. Now, we don't see too many patients, fortunately, with advanced liver disease. These patients need to go to a transplant list, and I don't think at this point giving them biologics is a good option. But you have to individualize treatment in these rare cases. Now, when you start these patients on biologics, it's very important to monitor the ALT levels very closely, and especially in patients who have fibrosis or cirrhosis, you have to be alerted all the time about the risk of developing hepatocellular carcinoma. We had a few patients like this who were taking anti-TNFs. I don't think TNFs were responsible, but you have always to keep that in mind if you have underlying fibrosis or cirrhosis. There are other means that you can follow fibrosis, and I think this is something that is evolving, and we're doing that a lot in Europe, and I'm sure it's being done now in the US too. We're using transient elastography, which is a non-invasive way to monitor fibrosis in these patients, and I think it's helping us a lot. And the point, you don't need to follow HCV RNA levels in these patients. There is no need to do that. It's not like hepatitis B virus. It doesn't help you much. So I'm going to switch to another virus, which I think it's my favorite, which is the hepatitis B virus, and something that I didn't know, and actually I read in a letter in Arthritis and Rheumatism a few years ago by Dr. Zweifler, who noticed that Bloomberg, who was the guy who discovered the virus, the Australian Addison, actually, he was trained in rheumatology back in the 50s. He went to NIH, but then he moved to Philadelphia, and then he discovered the virus. Actually, he received the Nobel Prize. So he's the second rheumatologist, actually, who won a Nobel Prize. So this is a double-stranded DNA virus. There are 10 different genotypes, which, again, you don't need to remember or check for that. It targets the hepatocytes. And what is different from hepatitis C virus is that this virus goes into the nucleus and forms this covalently closed circular DNA form, which is really difficult to get rid of, even with the best treatment, even when you clear the surface antigen. And the other thing that happens is that the virus randomly integrates into the host chromosome. And really, you cannot really get rid of this virus. The virus still stays in the liver. As I said before, this is much more common than hepatitis C virus. There are about 350 million people infected and 600,000 deaths annually from this virus. There is always some confusion about how you diagnose this disease. You have to remember, and we're going to talk a little bit about serology, that there are two types of patients when you have chronic infection. One is the most common one is what we call inactive carriers. These are patients who have the surface antigen, but they have normal liver enzymes, they have undetectable or low HBV DNA, and usually these patients do not progress to cirrhosis. The group that is most important are the ones who have elevated liver enzymes, and these are the ones who have chronic hepatitis B, which could be E antigen positive or E antigen negative. And you have to remember that even the antigen negative patients can develop hepatitis and can develop cirrhosis and hepatocellular carcinoma. So how do you make the diagnosis? I'll try to make it simple, although it doesn't look like one. The first thing you have to check always is the hepatitis surface antigen. You always check for core and anti-S. If you have the surface antigen, that means you have a chronic infection. Now, the majority of patients, as I said before, belong to what we call the carrier state. And in order to differentiate that, usually that's what the hepatologist is doing, is they check for the ALT and HBV DNA levels, or they do a liver biopsy. If you have elevated ALTs and DNA levels, then you have chronic hepatitis B. If these are, as I said before, normal or are detectable HBV DNA, that means you are an inactive carrier. Now, what happens if you don't have the surface antigen? If the core is positive, as Dr. Kush mentioned before, you have resolved infection. And if you're going to go into more detail, some of these patients, if you look carefully in the liver, you can find the DNA of the virus. And these are called occult infections, which may have some role in the reactivation rate, as we will see later on. If the core is negative and the S is positive, that means that most likely the patient has been vaccinated. And obviously, if everything is negative, this patient has never been exposed to the virus. Now, as it was the case before with hepatitis C, the same is true for hepatitis B virus. There is no difference in the prevalence between rheumatic patients and the general population. And why we get reactivation with immunosuppression? I think the reason is when you do give immunosuppression, you suppress the immune response against the replicating virus, and steroids actually act directly and increase the replication of the virus. So you get increased viral replication in the liver, you find that in the circulation, and usually when you stop or when you lower the dose of immunosuppression, then you give time to the immune response to develop, and then you get an exacerbation of the liver disease, you get hepatitis, which in some cases actually can be really dangerous. So that's the pathophysiology behind the immunosuppression-induced HBV reactivation. How do you define that? And I don't want to go into many details. Usually it's defined by an increase of HBV DNA levels by more than 1 log, or for a patient who was negative and becomes positive, this is reactivation. And usually, most of the time, that is being followed by elevation of liver enzymes. You have what we call biochemical reactivation. And the group that is in most danger of that is obviously the group who has the virus, who has chronic infection, although there is a small risk for patients with past infection. But I think what is more important, and this has been shown mainly in the oncology and hematology literature, is that if you get reactivation, you can have a really bad outcome. The mortality rates can go up as high as 40%. Now, who's at risk? I'm not going to discuss here patients who get short-term immunosuppression, let's say for a few months. This doesn't happen often in our patient population. Most of the patients we see is this group. This is the patients that receive long-term immunosuppression for chronic diseases that we're dealing with. Who's at the highest risk? I would say that the risk depends on what immunosuppression you are giving, and it depends what is the underlying HBV infection status. We know that steroids, especially the high-dose steroids, increase HBV DNA levels. There is a good evidence that anti-TNF and Rituximab do the same, and there are some recent data that abatacept can also do the same thing. We do not have enough data for tocilizumab or the latest biologics. And again, we do not have enough evidence for the non-biologic DMARDs. But if we take account how many patients we have treated all this year, maybe the risk is lower, but it's never zero. So this is how I think about that. As I said before, there are high-risk therapies like TNF inhibitors and Rituximab, but these data come mainly from the hematology literature. And if you look at the other side, which is the HBV infection status, people who are at the highest risk, patients who are at the highest risk, are the ones who have chronic hepatitis. That means they have very high HBV DNA levels when they start treatment. The ones who are at the lowest risk are the ones who have past infection and have anti-S antibodies. The risk for past infection, as we will discuss, is almost less than 5%. We'll discuss that. And I think this is something to remember. And just take a look at this slide again when you go home. Now, what is the absolute risk? Of course, you cannot do prospective studies in these patients, but if you look in the literature data, patients who have the surface antigen without prophylaxis, about 40% of those treated with anti-TNFs had HBV reactivation, and actually some of them developed acute liver failure or died. Of course, there's a lot of publication bias in this report, as we understand. And for rituximab, we do not have enough data from our literature, but if you go into the hematology literature, there the risk is much higher, almost 56 to 60%. There was a recent report from California when 4 patients that did not receive prophylaxis and were surface antigen positive and received abatacept developed HBV reactivation. So it appears that all these 3 biologics can induce HBV reactivation. There is a lot of discussion over the last years about what to do with patients with past HBV infection. And we have to remember that this is not a small pool of patients. Even in the United States, where the prevalence of the disease is very low, 5% of the population has past HBV infection. If you go to Europe, it's about 15%, and if you go to China, it's 50%, it's about 25% in Japan. So this is a huge pool of patients who have past HBV infection. And obviously, we had been treating these patients for many years without much happening, but this is something that we need to keep in mind. Now, what is the risk in these patients? Overall, it's much, much less compared to the surface antigen positive patients. We know that with conventional chemotherapy in the past, it was less than 5%. If you look in prospective studies in anti-TNFs, it's less than 5%, it's about 2%. And for rituximab, we do not have data in our patients. We have few data. I'll show you that in a minute. But if you look in the hematology literature, there is a wide variation ranging from 2 to 27%, but we have to keep in mind that these were retrospective studies, mainly from East Asia in lymphoma patients who got other medications too. We have done a small study last year when we looked at patients with past HBV infection, 12 of them, and we checked HBV DNA at baseline and during treatment with rituximab, and actually none of them developed HBV reactivation. We also looked at the anti-S, the protective anti-S antibody levels in these patients, the ones who were already vaccinated, and actually, again, we didn't see much there, following them for about 1 year. So this is still an open question, what to do. Now, are we screening our patients appropriately? As it was mentioned before, we're doing a better job compared to dermatologists and oncologists. All these studies are actually from the US, and actually about 70% of rheumatologists do the appropriate screening compared to about 40% of dermatologists and oncologists. Shall we do it for everybody? Again, the recommendations here are a little bit confusing, but I think it's important, as we'll discuss, to do it for everybody starting biologic or non-biologic therapy. How do you do that? This is a review we wrote with Len last year. You just do the serology. You do the surface antigen, anticore, and anti-S. As I said before, if you have the surface antigen, this is a chronic infection. If everything is negative, you have to discuss about vaccination. Discuss about vaccination. And the ones who have the NDS, this had been vaccinated in the past. And we will discuss what to do with the past HBV infection. Now, how about medication used in these patients? What are the recommendations? Again, the ACR recommends that methotrexate and leflunomide should be avoided. And if you want to use biologics, you can do that as long as you give antiviral treatment. And again, you do that only in patients who do not have advanced liver disease. And that's something that the Europeans also agree on. There are no recommendations at this point what to do in patients with past HBV infection. So this is an algorithm, again, from last year's publication with Len. As I said before, everybody who's surface antigen positive needs to get oral antiviral treatment. And these days, Nizar can help us with that, we use agents with low resistance. We prefer tenofovir and entecavir, and I'll show you in the next slide why. Patients who had not been exposed to the virus, you may consider vaccinating these patients. The ones who had already been vaccinated, you don't need to worry. And there is a question what to do with patients with past HBV infection. We have recommended to check the HBV DNA level. If it's positive, you treat them as the surface antigen positives. The ones who are negative, you need to be careful, especially, I think, when you give rituximab and follow them closely. Obviously, it's difficult. It's very expensive to do HBV DNAs every 3 months. I think this is what we are doing. You can just do the surface antigen and the ALT levels. And if the surface antigen or the HBV DNA becomes positive during follow-up, again, these patients are being treated with oral antivirals. Is this working? This is a prospective study we did some years ago. We had 14 patients with chronic HBV infection. And what we saw is that if you give everybody prophylactic therapy, everything goes okay. But at that time, we were using more lamivudine. And we discovered that about 15% of our patients developed reactivation due to lamivudine mutant strains. That's why we're not using lamivudine anymore. We're using the newer agents with low resistance rates. How you follow these patients, again, this is always done in consultation with your hepatologist. You are not doing this alone. You have to be very careful in this group of patients who have hepatitis or fibrosis, again, for the risk of hepatocellular carcinoma. And I mentioned before what to do in patients with past HBV infection. You have to, especially when you give rituximab, you have to be careful and follow the S antigen and probably HBV DNA levels in these patients. Now, if despite therapy, a patient has elevated liver enzymes, has elevated HBV DNA levels, then certainly change must be done in the antiviral therapy. This is something, obviously, that the hepatologist is going to decide. So to conclude, I think the message is that it's important to screen all our patients starting DMARDs for hepatitis B and C virus, and I think serology is enough. We're not worried too much these days in hepatitis C patients when you give anti-TNFs and rituximab, but we have to be careful in patients who have underlying fibrosis and cirrhosis, because these are patients who are at high risk for infections and other complications. Regarding hepatitis B virus, I think that I mentioned that everybody who's surface antigen positive should receive antiviral therapy before biologics. And there is a lot of discussion about patients with past HBV infection. I think the risk is very low with anti-TNFs. We don't know, as I said before, about the other biologics. We should be more careful with rituximab, although we do not have enough data in rheumatic patients. And in these patients, you have to follow carefully the ALT and the surface antigen. These are my acknowledgements, and thank you very much.
Thank you.